In this unit, we'll work on understanding how the respiratory and circulation systems are supposed to work. So we all know oxygen is needed to sustain life. And this presentation focuses on oxygenation. These are your learning objectives for oxygenation. Please familiarize yourselves with them and be able to answer them in preparation for class and for the exam. So objective 1 asks, how does gas exchange occur in the lungs? Well, air is breathed in, cleaned by the cilia, humidified by the mucous membranes, and warmed by capillaries close to the surface of the airways. Air goes into the bronchi, which are the big tubes. They divide into smaller bronchioles further down. Bronchioles end in tiny air sacs called alveoli. The alveoli inflate during inhalation and deflate during exhalation. Gas exchange occurs in tiny capillaries that are in the walls of the alveoli. Red blood cells travel through the capillaries, picking up oxygen and dropping off carbon dioxide. The carbon dioxide is then blown out of the body during exhalation, while the oxygen being carried in the blood goes to the heart. Objective 4 asks you to identify risks for impaired oxygenation across the lifespan. So in the elderly, the immune response lessens, which then increases the risk for infection and activity intolerance. A critical thinking point to consider then is, how does activity intolerance affect circulation? Another lifespan consideration is that in premature infants the lungs are not developed, which leads to possible episodes of apnea, which is not taking a breath for 20 seconds or more. So these premature infants, because of just central nervous system underdevelopment and lung underdevelopment, then have a twofold problem with the apnea and decreased lung inflation. Objective 2 asks you to describe factors affecting oxygenation. Body position matters here. So upright position allows the easiest expansion of the lungs, and know that there's increased effort if lying down related to abdominal contents pushing up on the lungs. So this is why people tend to use the tripod position to compensate for poor lung function, which is where they're kind of sitting upright and leaning forward, trying to breathe. Environmental factors include air pollution, such as respiratory irritants, and they cause increased mucus production, which contributes to bronchitis and asthma. And pollens and allergens are involved in allergic responses, which causes inflammation, which then causes small airways to become edematous or swollen with increased mucus production, and this can cause bronchospasm. So just know this is a priority for intervention because uncontrolled allergic asthma can result in death. Smoking contributes to emphysema, chronic bronchitis, lung cancer, oral cancer, and cardiovascular disease. It inhibits mucus removal by slowing ciliary action, which can result in bacterial infection. And drugs and alcohol, specifically CNS depressants or central nervous system medications, leads to lower respiratory rate and decreases of protective reflexes. So this can lead to aspiration pneumonia if vomit gets into the lungs. Nutrition is also very important, especially protein for strength and to prevent anemia. And muscle strength is needed for effective respirations and competent immune systems. Malnourished individuals are more likely to get pneumonia, and this is because they're not breathing effectively enough and they don't have the developed immune system. With restricted lung movement, a stiff lung or restrictive movement of the chest causes atelectasis or lung collapse, which results in less available space for air exchange. So disease processes resulting in restricted lung movement include COPD, smoke inhalation, pulmonary fibrosis, ARDS, which is adult respiratory distress syndrome, and pneumonia. And airway obstruction can be upper then as well, which is seen in croup and epiglottitis, or lower, which is seen in asthma, bronchitis, and bronchiolitis. So objective 5 asks you to describe how oxygenation can be assessed. So we begin with the assessment. We want to identify the client's normal breathing pattern. Do they have a chronic cough? Is it productive of sputum? What other signs and symptoms of infection might they have? We want to identify risks for breathing problems such as smoking, occupational exposure, low socioeconomic status, immunization status, and that's especially important for the whooping cough and pneumococcal pneumonia vaccines. Then we want to inspect for rate and pattern, color, effort. Is there cyanosis or is their skin pink? What is their physical appearance and their respiratory rate, O2 sats, chest expansion are important. We're going to palpitate for crepitus or subcu air, and this feels like Rice Krispies under your fingers. And we also want to palpate the trachea position and chest wall vibrations, which can indicate inflamed or fluid-filled lung tissue. We want to auscultate or listen for breath sounds. Is air moving through all fields? Are there abnormal sounds such as fine or coarse crackles? Rhonchi are the low-pitched sonorous sounds which represent fluid in the airways, and they sometimes clear with coughing. Or is there stridor, which is high-pitched upper airway problems? Or is there a pleural friction rub, which is like a dry rubbing or grating sound, which is caused by inflammation? Or is there wheezing? We want to also check for congruency of your assessment. For example, if the O2 sats are inaccurate with poor perfusion, movement, smoking, dark fingernail polish, or carbon monoxide poisoning, So if we know this to be true, we want to make sure that our values make sense with what we're seeing in the patient. So if you have a patient with an O2 sat of 60%, but they're pink and not cyanotic, they're breathing normally, and they don't have respiratory or level of consciousness symptoms, we're going to question the validity of the reading. And this, you just kind of got to think about it, because if an O2 sat truly was 60%, this would signify a patient on the verge of respiratory arrest, and so you would expect to see a very compromised patient with blue lips, and either they're going to be very restless and agitated, or they're going to be overly sedate if that reading was accurate. So we're going to include diagnostic tests in our assessment also if they're indicated. So think for a second of when arterial blood gases would be indicated. This is going to be for an asthma exacerbation, for COPD exacerbation, for pneumonia with respiratory distress, or if your patient is showing respiratory failure. Now, ABGs can be a bit complicated, and hopefully this chart helps to break them down a little bit. We're also going to discuss ABGs in class for this unit and in the fluid and electrolytes unit. So for right now, it's easiest just to focus on certain components of the ABGs, and then we'll try to put it more together later. So pH is the acidity of the blood and should be between 7.35 and 7.45. A pH above 7.45 is alkalosis, and a pH below 7.35 is acidosis. PCO2 is the amount of carbon dioxide in the blood, and this should be between 35 to 45. So just remember that PCO2 is the respiratory component of the ABG. Now bicarb, or HCO3, shows the bicarbonate level of the blood, and this should be between 22 to 26. Now bicarb is the metabolic component of the ABG, or a measure of kidney involvement in correcting blood gases. So note how the pH corresponds to either the PCO2 or the HCO3. The pH and PCO2 move in opposite directions for respiratory alkalosis or respiratory acidosis, and the pH and bicarb, or HCO3, move together in the same direction for metabolic alkalosis or metabolic acidosis. This can be remembered by the acronym ROME, R-O-M-E, which means respiratory opposite metabolic equal. So in respiratory alkalosis, the pH is up and the PCO2 is down. In respiratory acidosis, the pH is down and the PCO2 is up. In metabolic alkalosis, the pH is up and the bicarb is up. And in metabolic acidosis, the pH is down and the bicarb is down. We're not going to worry about the last column, which is compensation, for now. This will be covered later on. So take a look at these scenarios and practice applying what you've learned. Just jot down your interpretations in the notes column, and we'll discuss them in class. So objective 6 asks you to identify nursing diagnoses related to respiratory problems. There's a few listed here on this slide. Think of some of the etiologies of respiratory ailments: pneumonia, COPD, bronchitis, and know that you can't put the medical diagnosis, but just think of what's causing them. And then what are some manifestations of respiratory problems? You're probably going to see some shortness of breath with exertion, coughing, apnea maybe, tachypnea or rapid respiratory rate, or bradypnea, which is a slower respiratory rate. Then we move on to our goals, and remember, goals should be specific and measurable. And now these examples don't offer a time frame for completing the goals, so a measurable component would need to be added based on each unique client, but it gives you a general idea of some of the things you could say. Next, we write the plan and implement the nursing interventions, which meets objective 8, which asks you to suggest nursing interventions in the care of clients with impaired oxygenation. Now, this slide lists various nursing interventions to improve the respiratory status of patients. You'll learn more about the use of inhalers in your basic skills class, but just know that inhalers open up airways and decrease inflammation to promote the client's ability to clear the lungs of secretions. You'll also learn about the drugs in aerosol therapy and pharmacology class. And we won't cover them so much here because this course is going to focus on developing a plan of care that includes the use of multiple modalities to help treat illness. Now, as you read down the list, think about how effective coughing helps with breathing. And think about how pursed lip breathing might help. And one thing to note here is that chest physiotherapy is for people who are unable to cough up secretions. They put a vest on the patient, and this kind of taps into the patient or bounces the patient to loosen up secretions. So an example for this type of treatment would be for a patient who suffers from cystic fibrosis. This can be very helpful in helping them mobilize those secretions. And chest PT or physiotherapy is performed by respiratory therapy, not the nurse. So you don't need to know necessarily how to do it, but you need to know what it is and when it would be an appropriate intervention. So keep in mind that room air is 21% of FiO2, which is fractionated oxygen. And with each liter of oxygen, you add to the percentage of fractionated oxygen breathed in. So the amount of oxygen needed is unique for each client depending on their unique situation. But too much is a bad thing. It can cause alveolar leaking and respiratory failure, so the key point here is to only use as much O2 as you need to keep the O2 saturation in parameters. You want to titrate down the oxygen as soon as you can to prevent complications from hyperoxygenation or too much oxygen. Because what happens is your capillaries start to leak, and then the patient's lungs fill up with fluid, and then they are basically drowning in those secretions, which is caused from damage to their lungs from the oxygen. So the last step in the nursing process is to evaluate if your interventions were successful or not. You assess your plan and then ask yourself, do you need to change the interventions or goals to meet the needs of the client? If so, revise. If not, you can chart that it's met. So thanks for listening. This concludes the presentation on oxygenation. Just be sure to view the presentation on circulation as well prior to class. Thanks. Have a great day.